Good afternoon from Geneva. This is the resumed public hearings of the International Independent Commission of Inquiry on the occupied Palestinian territory, including East Jerusalem, and on Israel. We have been hearing evidence today in relation to the destruction of reproductive property and the impairment of reproductive rights of Palestinian people in Gaza and the West Bank over the last few years in particular. Our next witness is Dr. Saladin Sawan. Dr. Sawan, welcome, and thank you very much for coming to speak with us today. Could you please start by introducing yourself and telling us some of your background? You're then welcome to make an opening statement, and I may ask you some questions in relation to it to clarify or to add further detail. And if there are some matters that you haven't covered that we would like your opinion on, I will ask about that as well. So again, thank you for coming, and please proceed.
Thank you for having me, Mr. Commissioner. My name is Saladin Sawan. I'm a consultant surgeon in Gynaecological Oncology, which basically means I perform surgery to treat gynecological cancers. I've had my clinical training and academic research in the University of Manchester and Manchester University Hospitals. Where I did my PhD in studying ovarian cancer and a master's in endometrial cancer. I'm a full-time clinician, but I tend to do volunteer for humanitarian missions when I have time, and I tend to do 3 or 5 a year. I have visited Gaza toward the end of last year. I spent a month there, where I came out on Boxing Day, that the 26th of December. I was volunteering as a trauma surgeon. However, with my background as a gynecologist, I had my eye on women's health in this trip, where I could spot issues with women's health in Gaza. And I guess this is what we sort of can share with you today and answer some questions. I remember clearly in my first day when I arrived in one of the hospitals there, when I was told, oh, in the last week we had 3 maternal deaths. So that's really a high number. And then I looked after women with cancers, gynecological cancers and breast cancer, and these actually we can cover with you questions if you wish. That's
right. Well, are there any comments you would like to make as by way of introduction?
So I remember very clearly my first day arriving in Gaza, arriving Khan Shalom, crossing and going to Khan Yunis. It was going through ruins. It was no man's land for quite a bit, and of course I was with the United Nations convoy, which you have a clear instruction when to move or not. But I remember going through land of sand with piles of ruins, a lot of black pipes, so unearthed presumably when and digging the land. A lot of stray dogs, and you drive. It felt forever, but probably about half an hour drive going through these, and then you start meeting people, and by then it was about several months of blockade. They looked underweight and looked miserable, and that's how actually then you go into your hospital to do the work I volunteered to do. I made a habit at the time of making diaries. I tried to do daily diaries, and most what we sort of provide you with today was diaries taken at the time. I knew I was taking a risk, and I think I was prepared for the physical risk because that was obvious, but I was more worried about as a volunteering doctor on my emotions and psychological aspects. So I agreed with a friend that I would write to her whenever I fell down, that I said, really, I don't want to bottle things while I'm here. And that helped well, and it served the purpose. A lot of messages I sent was what I observed in there and providing today.
Thank you. Thank you. So what hospitals were you working at?
It was NASA Hospital, a complex NASA hospital. There were actually 3 hospitals, 3 buildings. The women and children was one of them. I was mainly based on the bigger building. They had different names, but I can't remember them, and where the actual trauma care was delivered.
And were you mainly dealing with gynecological cancer or more broadly?
No, actually, I was like a trauma surgeon, because that's the other part of my life, which I do in a stereo environment. So it's about damage control. You receive casualties with injuries, mass casualties. But when the team there realized I was a gynecologist, they invited me to. We did 2 main things. I've just mentioned the maternal death, so we tried to run some training about how you deal with critically ill pregnant women. And that was in a daily delivery, which is what I do usually when I'm in those missions. But also they asked me about caring for how to treat women with gynecological cancer. So prior to the current fighting, Gaza never delivered care, or at least surgical care, for women with gynecological cancer. They were always transferred out to Israel or to the West Bank. And because there was no chance of them, or extremely small chance of them being allowed out, so here you had this situation where you had doctors never treated those cancers, they never trained to do these cancers, and with women desperate for anything to be done for them. So I have a story of, if we pick on ovarian cancer, so that's a very, so I had a lady, well, I had 3 patients. One of them where I looked at the CT scan, so that's a way of imaging. You try to get into the idea, can you remove the cancer or not? And I thought I had a good chance. And when I treated her, unfortunately, there was the cancer already more widespread than what I anticipated, so I just removed the large lumps. Now, if this to happen in the Western countries, in the advanced society, that's probably not a big deal. She can go and have some chemotherapy and then plan further management. But this wasn't really a practical option for her. And transferring her out wasn't going to happen anytime soon. The other 2 ladies, I already anticipated the cancer was too widespread for me to operate or do anything to them. Sadly, one of them died after I left Gaza by a few days, and in the last week, I heard the other lady died as well.
And in your experience, in the normal course, would those 3 ladies' cancer have been treatable?
I think yes, and the reason I'm saying this, because generally ovarian cancer, even in our world, in the Western world, it does present itself in advanced stages, but we have a way of dealing with it. We can operate in combination of chemotherapy and other treatments, so these patients do survive. And nowadays, actually, with what we call targeted therapy, they survive for many years. Now, cancer will continue to grow. It doesn't care whether there is a war around you. Does not wait for peace. So as you're waiting for your treatment, the cancer will continue to grow, eating into surrounding tissues and spreading around. Generally, it's acceptable to treat. I came from the UK, so our target is to treat women with cancer within 61 days, for example. And this seen around the world as being too flexible. You know, there is emotional side when you diagnose with cancer as well. So these women in Gaza waited for much longer than that. Different cancer grow at different speed, but the time these ladies waited was far too long, and yes, and I suspect it's very likely, if not definite, that they succumb to their cancer for lack of treatment.
Right. You mentioned that cancer surgery or gynecological surgery for cancer was not occurring in Gaza previously. People went to Israel or Palestine or to the West Bank. Was there chemotherapy or radiotherapy possible in Gaza, or was that treatment also external?
I think they would deliver some chemotherapy to particular cancers, and I suspect ovarian cancer would be one of them. However, I do not think they had radiotherapy. I mean, I think radiotherapy would be something delivered in more advanced centers. And certainly there was no radiotherapy when I was there, and there very is scarcity of chemotherapy to be offered as well.
Right. There was some chemotherapy, however,
There was some chemotherapy given at the time, yeah.
Right. And was that at Nasser Hospital or other hospitals?
I'm not entirely sure. The reason I think there was some chemotherapy delivered because there's another patient who was actually happened to be a doctor, and she had a sarcoma which needed surgery, no doubt about it, but I was told she was given 2 shots of chemotherapy, 2 cycles of chemotherapy, which shrunk her cancer.
Right.
So that's why I know there is. But my patient, the patient I looked after, there was no chemotherapy available to them. So I suspect there might have been some offered in a very limited amount.
Right. Did you see or treat pregnant women or immediate postnatal women for any of their conditions?
I do not do obstetrics a lot, but when I operated on cancer patients, so I operated in the same building where there were women and babies. We had discussion. I attended the daily morning hand ward round where doctors of the night shift will hand to the morning, so I was fully aware, I was to some degree aware to what was going on in the hospital. I mentioned earlier there was, the week before we arrived, 3 maternal deaths. And I think given the number of deliveries in the hospital, we'd expect that number to be for the entire year. Now, I communicated with my colleagues on land in Gaza, and they told me they had last year about 15 maternal deaths. So it's about 12 or so more than what they expect. So the United Nations reports would say in 2019, Gaza's maternal death is it's about 29 in 100,000 or so. So that equates to Nasser Hospital would have had only 3 deaths in a year. But during the fighting, that has 5-fold increased. Now, we know from published research elsewhere that maternal death goes up during fighting, during war. We know that's been published. In fact, women tend to have higher risk of dying, irrespective whether they're pregnant or not, in conflict zones. And I think one of your interviewee yesterday talked about women having it. Very, very few wars actually were ordered by women, and very few armies were entirely or almost entirely made of women. Then women tend to have the consequences of it, and this is a really sad truth about what we do. And I think your interviewee yesterday said actually women who were subjected to sexual insult in the prisons, that there was some evidence they also had domestic violence following that, so they tend to have it both sides. And this is really, that sums up the case of women in the conflict zone. They tend to have a bad time, really bad time.
Yeah. With you mentioned earlier about that there had been 3 deaths before you arrived. What was the period of that again?
It was over 2 weeks.
Over 2 weeks.
Yeah.
Okay, thanks. Do you know whether that kind of death rate has continued since December last?
So now when I'm coming here, I asked my colleagues how many deaths they had in the last year, and they said 15. Prior to fighting, they would have had 2 or 3. So right. That's sort of, and that actually in keeping with the numbers reported by the United Nations
as well.
Yeah, so it equates the same numbers. Yeah.
Right. Okay. Yeah. Thank you.
I could talk about another case if you wish me to, which is a vulval cancer case.
Yes,
That is
please.
cancer of the genitalia. Now, generally in our Western practice, we would operate to a particular stage, after which we think chemotherapy, radiotherapy is the best for patients. Now, this lady was diagnosed with the cancer 6 months prior to my arrival. She would have been transferred out. She was in the waiting list to be transferred out, and there was no chance. I met her, I repeated her scans to know how far the cancer spread, and by then it was what we call stage 3C, so it was fairly advanced, reaching the lymph nodes. And I just said, honestly, if you were my patient in Manchester, I wouldn't offer you surgery. And it was ethical dilemma to me, and it was hard decision and difficult decision to her and her family. And eventually, we reached a decision, if I operated on her, that might buy us some time, because at the time, there was some talks about the truce coming into Gaza. And we hoped that is, if I operate on her, 6 months, 6 weeks or so, she will be ready to be transferred out. I operated on her. As it happened, I had a colleague who was a plastic surgeon, so we thought surgical skills, we had a really good team. She ended up with the wounds breaking down, and the operation is really big operation. And perhaps I shouldn't be surprised, because she left in a tent. There was no chance of keeping hygiene of her surgical wound.
Yep.
We kept her in the hospital as long as we could. And she's still in the waiting list till now. So I checked on after her 2 days ago, and she was still not able to be transferred. She's still in the waiting list. Now, the waiting list is by WHO and COI.
Yep.
And you can only make it to that waiting list after being recommended by an expert. So there is a waiting list to be in the waiting list in a way. But the numbers for the waiting list, which is, I got the figures from the United Nations, as well as a report by the BBC and the Times of Israel. And about the time I was in Rick Pipcorn, I think the name, who is the WHO representative.
Yeah, peppercorn, I think.
I'm sorry for the pronunciation.
No, that's good.
So he would said about between November and December, there were only, so that 27th of November to the 24th of December, only 29 patients made it out of 14,000 waiting. So that 2.5 in 1,000.
Yep.
And as I said, the already people waiting to be in that waiting list. And you can tell this actually, I was told at the time that prior to the blockade on Gaza, you would have 50 patients going out every day, more or less, but 29 in a month.
Mm-hmm. I know that there have been a few hundred who have got out since the ceasefire started, but again, it may be 300 or 400 out of the 48,000 that you're talking about. It's still minimal.
Absolutely, and these patients, I mean, and bearing in mind, and I guess we're talking about here about elective cases, what we call elective cancer, majority of patients being transferred, so above what you would have normally needing to be transferring out of Gaza, you have all those injured in the war. And it was, in a way, the war actually consumed the health system. So those patients with cancer, not only did they not have their treatment for the lack of the expertise and the skills, but also because the health facility is consumed by injuries caused by the fighting, by the war. So, for example, my patients, when I do big operation, I would require intensive care unit, ICU or ITU. But there was no chance of having those because already occupied by badly injured people. So there is that effect as well. You couldn't do cancer surgery because there is no space in theatres or beds in the hospitals.
And so for those people, what is the prognosis?
It's grim. It's I'm questioning myself for those patients I operated on, like the vulval cancer lady. Did I do her any good? Probably I did, because we know when the cancer spreads into the lymph nodes in the groin, one of the ugliest deaths can one have. It is really bad death, and I will always try to remove those invaded lymph nodes to make sure, try to reduce her risk of that consequence. It is certainly compromised if you don't deliver all the care. She would have needed to go out for chemotherapy and radiotherapy within 6 weeks or so. She hasn't, so there is a higher chance of the cancer coming back and succumbing for the disease.
Because she didn't have the chemotherapy during that 6 weeks, does that mean that now chemo is of no use, or just less?
It is debatable. I'm a surgeon, but when we do the MDTs and discuss with our colleagues, because sometimes for whatever reason, let's say I operated and the wounds did not heal on time, there is quite a bit of discussion. So they could be a bit more relaxed, but they would say the research which showed this treatment is going to work was done within a specific time. So, we try to follow best evidence. But ultimately, you have to make a judgment call. So I would say we suspect it will be less effective because the research showed you deliver the chemoradiotherapy within a window of time that would work. After that, we really don't know, but we suspect will be less effective.
Right, okay. What is the impact of gynecological cancer on the reproductive system?
It is, it depends on which cancer and whether you can manage it with what we call fertility sparing. So cancer tend to affect older women generally, but you have cervical cancer, that the cancer of the neck of the womb, tend to affect younger women. And if you do the hysterectomy, that will basically take the possibility of getting pregnant. It feels mutilating, so when you treat vulval cancer, that affects self-awareness and could be seen as disfiguring. So that's not trivial at all, and that will affect relationships and the rest of it. Breast cancer was an interesting case because generally, if we pick breast cancer early stages, you can send your patient, you can do a limited operation knowing they can have radiotherapy afterwards. But because this wasn't available in Gaza for the same reason, so surgeons there opted to do a bigger operation. So we went back 40, 50 years in the practice to sort of give a better chance of lower recurrence risk.
Right.
And that is, so what I'm talking about, difference between removing the lump itself while removing the entire breast, and you can see the consequences psychologically and emotionally in the woman after that.
What is the availability of equipment for testing, scans, MRIs, and so forth?
We had only one CT scan machine, and we did not have the contrast. So that helps us to see where the cancer and what's affecting. So each time I had to do one of my patients as a visitor. So I was given a bit of respect, and my patient would be given the contrast. So so that wasn't particularly available, and the machine, 24 hours working and no maintenance. There was no MRI machine where I was, no PET scan. Histopathology, they had 2 or 3 of their senior histopathologists disappearing and either killed or left. So then you ended up with more junior colleagues reading the histopathology, because nowadays it's not enough to tell me there is a cancer as a surgeon. I want to know what type of cancer and all the rest of it. And that wasn't. Some testing were not available called immunohistochemistry, so they need a special dye, if you would, to be used, and that wasn't available. For the breast, usually try to take a biopsy rather than just removing the lump in case it's benign, so you don't need to do big operations. So true cut biopsy, which is a simple instrument, but that wasn't available. I was operating once, and it was a trauma case, and when she finished, I wanted to write the operation. That was like in the first day or 2, and there was no paper to write your operation notes on. So because that was banned, not allowed into Gaza, so we would use the packaging material for medical instruments to turn it upside the other side, cut it into 2 pieces so you can write 2 operations notes on it. Is that level? It was beyond imagination. Well, honestly, it wasn't prepared. I mean, I tried my best to be prepared to my trip to Gaza, but it was beyond what you would expect. Yeah. My surgical instruments, of course, I wasn't expecting what I would use in Manchester. But I thought it would be about the same when I used in Idlib, another place I visited and operated and helped doctors in there. But it wasn't that good because instruments were not maintained, so maintenance wasn't available. So you just keep using the scissors, whether they cut or not. You're lucky you have scissors in your hand. And the same for more complex surgical instruments.
And were they able to be sterilised before you were using them?
Yes, so they will be sterilized, but it's not the same technique we use here as my understanding. So we use formalin, for example, occasionally, and they use the autoclave, but not the same thorough sterilization we do in the West. Yeah.
So there was a greater risk of infection as a result.
Absolutely, yeah. I mean, there was no antibiotics. I mean, I knew before going in there. I once performed an operation on a patient, and we ended up doing what we call ileostomy, which is to bring small bowels out through the abdominal wall, because to protect the rest of it. It was a trauma injury with shrapnel injuries, and but we had to bring it sort of surgical way. And one of those problems with these, you can end up with the content coming too fluid, too liquid, and that could cause dehydration. So here we can use tablets, loperamide, which you use for travel diarrhea and things, but this wasn't available there. So it was simple. Now, I tend to take my own loperamide when I travel because I know what I end up with. And I had to give my own medication, which I use actually just for me as prophylaxis in case I end up having trouble, to the patient there, because losing so much fluid through that will have consequences on her health.
So were you able to take any instruments or medicines, medications in with you?
So before you go, and when you're vetted, and you are told what you can't take with you as a doctor, and you will feel responsibility because the organization I went with were allowed only 4 doctors every 4 months. So you will feel responsibility not to dare or risk not following the instructions, because you're keen on the NGO taking more doctors in the future.
Yeah. So,
for example, we were allowed only 3 kilograms of food, and staying in. So basically, I went to Gaza and ate Gazans' food, with the little food they had. I mean, I lost weight while I was there, though I was treated as a guest and was given the best food and all the rest of it. And medical instruments were, in our mission, they was allowed to take a handheld ultrasound machine that we were told it's okay to take it, but nothing more than that. I took my loupes, which is a sort of surgical magnifying glasses to use, but that was okay to take as well. But no instruments like fancy instruments or big instruments. I don't think we were, the broad instructions were, you take only for your personal use medications, tablets, and there is specifics on what you can take, amount of money you can take, amount of food and medications.
Was any reason given for the restriction 3 kilograms of food?
I asked, there was no clear answer, and I wasn't clear actually whether they were referring to 3 kilograms of food that you carry in your hand or you put in your luggage, but I think that was all what you can allow to take, and I think they was just assuming that to cover your trip, because we would start in Amman in Jordan, right to Camp Shalom. And I think that took about us 4 or 5 hours of journey. I think that just to cover you during your journey, that probably what was the purpose. So they were not expecting you to take food with you I mean, during 31 days, I think we had only once a cooked meat. I mean, that's type. I mean, when we're talking about wounds not healing because of malnutrition, and that's been reported by particularly plastic surgeons and my patients' wounds, that for the, there was genuinely there was a malnutrition, there was starvation in there, and only once we had that meat. So there is a dish which is known for Gaza, it's called magluba, and our host, the team was looking after us during, decided they wanted to feed us that food, but they said, sorry, there is no meat, so we'll call it fake magluba. It was touching, really touching. They tried to look after us. I know they did.
Yeah.
But that is what they were sort of. there was a lot of unnecessary suffering. I mean, a lot of instructions were not clear to me. Why? But I'm not a military person. They must have thought if you take that, might reach somebody. So I'm not that. I don't know much into that. But there were so many things, like where did not look had a purpose behind them, and it just makes you wonder whether they were just trying to make your life as difficult as possible, so you don't go back again, or make it more difficult to future missions to make it.
Well, I mean, what occurs to me immediately, there are two consequences of such a food limit. The first is that you won't have food to distribute to anybody in Gaza. But the second is that after a day or two, you would in fact become a burden on the food supply available to the Gazans.
And that's what it was. And we were very careful. We know we were treated best, and because that's what people do for their guests, and they appreciate our presence in terms of the help we give doctors, and that is, you sort of, you can't help it. You would feel guilty eating the food, limited food. I made the mistake once, mentioned I actually like my fruits. I do like my fruits. So it was a doctor who actually went out and bought me an orange. Now, it's a really small orange, wrinkled. If you found it in the back of your fridge, you would throw it away, you wouldn't eat it. And then the price for that was $18. At the time, that is December time last year, that's how much he paid to get me that orange.
Small orange.
For small orange.
Yeah. And similarly with medicines, you're only allowed to take in medicines for your own use.
Only for my own use, that's correct.
So you couldn't take in any more powerful painkillers or any chemo drugs?
Certainly not. So when you go, everybody keen in keeping the mission going, NGOs. So there was the COGAT, WHO instructions, and we all really, because we had responsibility, as I mentioned earlier, for future mission. You don't want to do anything seen silly that will impact future missions. So I tend to follow. So, you were told to take paracetamol 3 boxes or 2 boxes, you will take a third one and risk it. That's sort of what you do. But chemotherapy were clearly not to take. The reason I'm saying this, because I know patients who have a kidney transplant, for example, they will continue with immunosuppressants, and there was a huge need for that, for immunosuppressant for those patients. And one of the doctors secured some immunosuppressant as a donation and just couldn't take them in. He was told they clearly don't.
Do you know who set these conditions?
My understanding, it's COGAT.
So the Israeli authorities?
It is the body in the IDF responsible for liaison with the WHO for Gaza and other parts.
Okay.
But I couldn't be 100% sure.
Yeah, no,
but that's what I was. But that's what
just
was under the
understanding.
impression. Yeah.
Right. Did you treat any girls or all adult women?
So the girls I treated was a trauma. So she was in her tent, and that was not unusual. So when we had mass casualties, you end up having mainly ladies and young children, and there would be few men, but by my observation was largely ladies and young women. So on one occasion there was a 14 or 15 years old girl who came with multiple shrapnel injuries inside her abdomen, and that the girl, I did her surgery. So I don't think she was the youngest. There was part of the work I did was plastic surgery as well. I supported my main plastic surgeon. So that's what you do when you're trauma surgeon. You tend to cover all these emergency. And I remember her name, I'm not going to say it. She was only 2 years old, and by the time we finished, we performed some 17 operations on her. So the story, because the tents were easy to catch fire, and they, of course, they don't even stop people, so they almost transparent. So, and that's why you find problem with people not able to take care of their own hygiene, because you will be seen outside. So when these tents catch fire, so this girl got burned in the whole side, and with the damage control, you do it to save life. So her arm was just very stuck to her body because the skin contracted and you can't open it. So when we were there, we had the right specialty, a reconstructive plastic surgeon, and you try to do a bit every day to try to help her to expand. She would cry every day. Now, people there haven't seen chocolate for a while, and that in the grand scheme of things of nothing. I knew that before I went, so I took a small box of little chocolate, and I tried to save as money as I can for this little girl, just to cheer her up before another big operation. She was fearing and crying. There was one day when we had mass casualty, and when you have those, you sort of have this connection with the truth, with what's going on. You try to focus on your work, and there was this boy crying for his mother, left alone in the corner, because everybody busy dealing with the casualties. And it always call you back to come to the real life. This boy, we need somebody to comfort him. He was like 4 or 5 years old, and somebody to console him, and nobody available, just because we're all busy treating the damage, and that sort of, still that image is still with me, because I don't know what happened to him, but he was alone. He was alone.
You mentioned that you had worked in Idlib, and you said there are other humanitarian missions that you've done. How did your experience in Gaza compare with your other experiences?
It was the worst experience, and somehow the situation in Gaza managed to collect the worst of each mission I went to, in that Idlib in many ways was at the time when I started working with them close to Gaza in that it is surrounded, blocked, but the border with Turkey and Idlib allowed some help to come through, which Gaza did not. But in terms of insecurity, of bombing, was similar to what you expect in Gaza. And lack of food, lack of clothes, people walked barefooted, and the lack of medication, and as we talked about, and not great surgical instruments. You ended up trying to do operations, probably not fully supported by a team, never done it before, trying to do your best for your patient. It was one of the worst, it was the worst experience of mine in terms dealing with women's health. I mean, casualty, that's a different world.
What do you see as the long-term consequences for women of the situation you describe?
I honestly think, and I mentioned research before when they talked about women's death during conflict, and that part of the research looked into after conflict, so during the conflict, because that will carry on. Because by the time, say, there is a truce now and hope will hold on, now you're going to discover more cancers. So because those cancers we were told about, because they were so advanced they couldn't hide themselves anymore. Women, a lot of men were lost, so you will have a lot of women now needing to look after the family. There was a research done, just to explain this point. So they looked into newborns, and they compared those who lost their mothers at birth to those who did not. And they found the chances of dying if you lost your mother by the day 42 is 35.5 times higher than if you did not.
35.5?
0.5, yeah, fold increase. Let's face it, women tend to be the glue having our society together. They hold this family together, they hold the society together, they look after the family. And in some societies, they are the breadwinners as well. So losing a mother has its consequences on the family and the society. What's going to happen in Gaza, I suspect, will take long time to recover. You need to improve the health system, rebuild it, because it was almost in ruin when we were there. And it's not going to benefit women immediately, will take time. So I think more bad news to come, I'm afraid.
In the time you were in the hospital, did you see anything or hear anything that made you suspect the hospital may have been used for military purposes by one or other of the Palestinian armed groups?
I mean, when I do those humanitarian missions, I go, I'm focusing on patients, and so actually to realize these things, they need to be right in my face, sort of. I do not look for those. I did not see throughout my stay in the hospital any armed person or anybody in a uniform. I can tell you that, but I actually did not actively go and look whether they were.
Well, you were there as a doctor.
I was there a doctor. I mean, and you probably know there were no journalists around allowed into Gaza as well. So I felt part of it, and I guess that's why I felt I need to be with you today, because the voice of women in Gaza need to be heard to get to the truth, but more and importantly, to stop the suffering they're going through. So, yeah, but I did not see any. I mean, you can see because Nasser Hospital was taken over by the IDF, so you can see the sign they put on the doors when they, and my understanding, every time they search a room, they put a sign that they searched it, and that was everywhere. But I did not see. When you had mass casualty, and actually that I was wondering, when you have mass casualty, would you have militant coming? So I did not. And my observation for the mass casualty arrived at Nasser Hospital, and we did not have all of them, so they would have gone elsewhere. They were mainly family members, like women, children, older people. We had some young men as well, but they did not strike me as being militant and so on. So I did not know.
Right. And you saw no evidence of weapons being stored?
No. I did not see throughout my stay in Nasser Hospital any sort of form of weapons. We were made or told to stay in the hospital, so we stayed day and night in the hospital, because 4 or 5 missions prior to ours, there was some bombing beside the area. The doctors were rested, and it felt safer for us to stay in some same place. Now, I knew emotionally I probably wouldn't cope by staying 30 days or 31 days, so I opted to go out to the guest house, taking the risk. So that allowed me to see Gaza and my travel coming up and down. And I don't remember seeing armed people in those trips. I met twice outside the hospital.
Right. Yeah. Was there any part of the hospital where you were told you couldn't go or shouldn't go?
No. I mean, for our security, we had our floor, we were stayed, and so we sort of not to have strangers coming into our place. And I was told, they knew the floors where I go and operate. As I said, there were 3 buildings. Initially, they told us if you go outside this building to go to the obstetrics and gynecology building, let us know. But then that was eased off. But we were not allowed to get outside the complex and the surrounding wall.
Of the hospital itself?
Yeah. So you're right to walk around and go in between buildings, but do not leave the complex area outside because there was for safety. I mean, we was told that for our safety. Mm-hmm. Yeah.
You mentioned about your concern that the voice of the women be heard. Did they say to you, please tell people something when you were there?
Yeah, and I think people do cry. So these cancers I dealt with, they were the message, can you go and tell the world, please? And I would say, look, this wasn't a part I was expecting to do, but if I have opportunity, I will tell the truth as I see it. But more, you had a bit of quiet word with your colleagues, nurses, lady nurses, and others. And these are the ones which really to be trying. Women generally do good at multitasking, but these women were so amazing, trying to keep the family together in a tent, come to work to help us out. And you see, as a worker, you can't go out of the hospital the time you choose, and there were buses with specific times in the morning, and you leave, because that all coordinated, to my knowledge, So you're allowed to go to your tent and come back. So it's not like here, you can be late for your work and get in your car and go home. You would receive a call asking you to go and evacuate your tent and move it because it's been decided it's an area with the next operation. I mean, one of the doctors I worked with already changed their tent 6 times. 6 times. One of the casualties...
Sorry, in what period was that?
I suspect throughout the conflict area. Sorry, I did not ask when that started, but they said he moved his tents. And you need to go on a queue for the food as well. So as a doctor, you need to leave on time to catch the only bus, the only transport, and to go on a queue for your food. I remember once there was attack on the World Central Kitchen, and
Yes.
and one of the casualties came, and it turned up to be a vascular surgeon working with next door hospital, nearby hospital. Now, vascular surgeons, where there were very few of them around, and they were really needed in this part. So it turned out he was queuing for food after finishing work, and there was a attack beside him, a bombing, and he was badly injured, and he came as a casualty. You get used while you're working there, whether your colleagues will turn up tomorrow or not. They could be killed. They could be somebody, their family killed, and they're coming back. Or could be simply just moving their tent. They were given orders and they needed to move. Death was always around the corner. Yeah. So colleagues were really saying, we've had enough. They thought at the time that before the truce they will go back to their houses because everybody was full of hope. Once the truce comes, then they leave the tents and go to their houses. And I received so many messages afterwards that actually we went to our house. It's not a house, it's just a ruin.
Yeah.
We spend the rest of life in tents, so that's another thing. Yeah.
Do you have any thought of going back?
I would love to go back. You tend, as a humanitarian surgeon, feel you connect with people, and when I go back, and it feels a sense of disappointment on your last day, and that was Gaza, was elsewhere I've been to, but because you feel there is more to offer, and the kindness of people there is just overwhelming. So I would love to go back. I mean, if I have the opportunity, I would absolutely go back, and I would certainly try to go back to help those people. When I arrived in Gaza, I had the image going to see, I don't know, fighters and people who are strong and ready to fight. I found people who were really hungry, really tired, really, really tired, and they just had enough. So straight away, you imagine this is not actually what the outside world thinking of this, of people in this part. And bear in mind, there were no journalists allowed, so actually nobody was able to get this picture. So they deserve to be supported, and I hope peace will come and everybody live in peace in the area there.
Thank you very much, Dr. Sawan. I don't have any other questions. Are there anything that you would like to tell us in addition?
No, thank you very much for your commission, and I think I hope peace come into that part of the world. We all
do, I think. Certainly all the people in that region deserve it.
Absolutely, absolutely. The whole region had enough.
More than enough.
Yeah.
Thank you for coming. Thank you for giving us so much insight that you acquired by being there. We're not able to go there. The Israeli authorities prevent it. But for that reason, we depend on people like you to give us an eyewitness account of what is happening. So we need to hear from people like you, and we greatly appreciate you all telling us. Thank you.
Thanks very much, Mr. Commissioner.
Thank you.
Thank you.
We will adjourn for a short break, resuming in around about 25 minutes at 4:15 Geneva time. Thank you.